Olá pessoal, bem-vindos a mais um episódio de Clube da Artéria. Hoje nós temos um Clube da Artéria com um convidado internacional. O Clube da Artéria é uma iniciativa da pós-graduação do Centervasc Rio. É um prazer estar aqui mais uma vez com todos vocês. Hoje temos o prazer de conversar com o Dr. Houman. Ele é cirurgião geral e cirurgião vascular. Ele é head do European Venous Centers em Arno, na Alemanha, né? É um prazer muito grande estar com ele aqui hoje. Vou passar a palavra aqui para o Dr. Arno agora.
Bom dia a todos. É realmente uma grande alegria, uma satisfação poder contar com a presença aqui do nosso colega Houman Jalaie, da Universidade de Aachen, na Alemanha, que é uma das maiores experiências mundiais no tratamento das doenças venosas com método endovascular. Apesar de ele ser um cirurgião vascular com formação em cirurgia aberta, conversávamos aqui que ele entrou e participou e fez muita cirurgia, inclusive de aneurisma tóraco-abdominal, com aquelas incisões documento, não é, Bernardo? E com isso nós vamos ter assim, a oportunidade de ouvir essa experiência muito grande que vai abordar, sobretudo, a doença aguda e venosa e a classificação, que é uma classificação original dele, que tem sido utilizada mundialmente por todos e que merece ser amplamente divulgada. Jalaie, com a palavra.
Welcome.
Thank you very much for inviting me. I cannot speak Portuguese, but I did understand a little bit. So I'm very happy to be in your nice country, especially in this nice city of Rio. Yesterday I had the time to see a little bit of Copacabana and some other parts of Rio. So let us start.
Yeah, thank you very much. Could you talk with us on your formation? As you started, we started working with vascular surgery, thoracoabdominal, and where did you do your formation and how you change into focusing on venous?
Yeah, so originally I am from a big aortic center, so my mentor, Professor Michael Jacobs, at that time he was the chief of the University Hospital Maastricht and University Hospital Aachen in Germany, and Maastricht and Aachen, they are very close to each other. You can drive with the car 25 minutes, 30 minutes from one city to other city. So I had the privilege to learn from him, especially he's very famous in open thoracoabdominal aortic approach. So normally I am general surgeon and a vascular surgeon, and I had a lot of experience because of him in this field. But at that time, also Professor Kees Wittens, also a friend of Michael Jacobs, you know him. He came from Rotterdam to University Hospital Maastricht, and together with him we started the Venous Center to end of 2009, 2010, beginning of 2010 in University Hospital Aachen. All of us vascular surgeons, we do a venous work in our weekly work or daily work, but we really started to focus on veins, starting local awareness. Then we went to national congresses, and then of course international. We started with focus on varicose veins, but also pelvic venous disorder and deep venous pathologies, acute DVT, PTS, NIVEL, and that time. So it was not only daily work, we focused also on research. We had PhDs, doctorate students. So with that, 2012, 13, 14, we grew up to one of the biggest European venous centers, and we had referral centers from all parts of Germany and also some other European countries, and also countries maybe in Middle East and other centers. So yeah, from that time, my focus went to venous. It was not because, the reason was not because I didn't like aortic. I loved aortic surgery, but I think I needed to focus my research on one point, and venous was the deep venous endovascular treatment was very new, so that was my decision. Now I am doing only venous cases.
No, fantastic, fantastic. And what we here in Brazil have all surgeons, all vascular surgeons in Brazil have a big. We have a lot of concern regarding venous disease and venous pathologies. In Brazil, the venous interventions is a huge thing. We are also concerned about either endovascular treating obstructive disease or also treating phlebology and lower limbs. Here it's very important for all the vascular family in Brazil, all the vascular surgeons, and so it's a topic that interests a lot of us here in Brazil. And nowadays in Europe, how do you feel is the interest of the vascular surgeons to the venous field?
It's growing. Absolutely. So if I compare with maybe 20 years ago, the beginning of my vascular surgery, it is absolutely more now. At that time, 20 years ago, the endovascular era in the venous field was not that advanced. Now we have really advanced techniques, endovascular techniques. We improved them. We have new stents. We have new results of the studies, maybe more evidence. And for sure, now the venous is one of the main parts of the vascular surgery. Not only vascular surgery, also for angiologists, for some interventional radiologists, for some phlebologists who are not vascular surgeons. Yeah. So, and very important is people now, colleagues, referral doctors know that phlebology is not only varicose veins treatment. Yes. So we have also pelvic venous disorder. It is combined with varicose veins. We have acute DVT, we have post-thrombotic syndrome, we have the May-Thurner Syndrome, and all those pathologies are somehow combined. So it's a holistic approach.
Yes.
Which makes it maybe more interesting, of course.
Yeah, that's true. Yeah, totally. We totally agree with you. And as you said, I think the main thing is the diagnosis. What you could talk to us about the diagnosis of those patients and diagnosis of NIVO and to search for that, and patients that sometimes visit several family physicians with complaints and could never find a proper diagnosis.
So, of course, I think in all fields of medicine, diagnosis is one of the most important steps, and then patient selection. So in the venous is the same. Maybe in some venous pathologies, more like NIVEL, you use the name May-Thurner Syndrome or NIVEL. In this pathology, I would say diagnosis is very, very crucial. Why? Because we know today there is an overdiagnosis and overtreatment, especially in US, regarding the NIVEL. And that was also the reason a few years ago that led to many cases of migration of the stent, which also led to the fact that one stent had to be recalled from the market. That was not the problem of the stent, that was the problem of overdiagnosing and using the stent in a wrong way. So therefore, let us focus on NIVEL, on May-Thurner Syndrome. This pathology is very, very difficult to be diagnosed. So maybe, if you like, we could start with the presentation, and then we can go step by step.
Good.
And I would then, together with you, we can comment on it, why it is so important.
Perfect. So let's start.
So as we discussed, we prepared this this presentation. So to make it maybe clear, the focus is now May-Thurner Syndrome. May-Thurner Syndrome is one pathology of the deep venous pathologies, which is a part of our focus. This is my disclosure. So, as a general consideration, if we talk about May-Thurner syndrome or NIVEL, we should note that those patients can come to you in 4 type of pathologies or in 4 classes. So I would say the first part of the patients are referred to you with a NIVEL. So a phlebotomist, a doctor somewhere sends the patients to you and tells the patient has a NIVEL, only NIVEL. So there is no DVT, there is no post-thrombotic syndrome, there is no pelvic venous disorder. So those patients come to you with only NIVEL. Those patients are very, very seldom. So in those patients, the pathology is extremely crucial because not every compression or waste is a NIVEL. There should be a clear corresponding complaints. And the complaints of only NIVEL is swelling of the entire leg, heaviness, tension of the entire leg. We should be really clear. It is not only swelling of the ankle or the lower leg that could be the reason of a varicose vein. If there is a clear hemodynamically relevant stenosis, like maybe on this phlebogram, then the entire leg should be swollen, there should be tension, then we can discuss about it. The second group of the patient, which is more common, I would say 1/3 of my patients are those ladies with pelvic venous disorder. As you can see in this phlebogram, there is a clear insufficiency of the left ovarian vein, but maybe also a hemodynamically relevant compression of the confluence of the cava, the so-called NIVEL or May-Thurner syndrome. And we see also enlarged pelvic veins as a pelvic varicose veins. This is the second group. The third group of the patients, they come to you or are referred to you with acute DVT. So the gentleman or lady comes to you with an iliofemoral acute DVT, and then let us assume you decide to treat the DVT because it is iliofemoral, because it is acute, the risk of bleeding is low. So you demask the underlying disease. As you can see on the right phlebogram, the DVT is removed, and you see a clear underlying disease, which is the NIVEL. Also here is very clear that there is a NIVEL and it should be treated. The fourth group is the group of patients who had a DVT 2 years ago, 5 years ago, or maybe 20 years ago. They developed a chronic venous obstruction, a PTS, and now you decide to treat them with a recanalization and stenting. You should take care for the proximal landing zone because maybe there was the reason of the DVT was a May-Thurner syndrome, as you can see in this daily venous map of our center. So these are the patients. Now, the diagnosis and correct selection of our patient. The most important tool of the diagnostic is duplex. Of course, you talk first to your patient. You take the anamnesis. You take in consideration patient's past medical history. Then maybe you can already decide, is it a real NIVEL or not? If patient tells you, I have an upper abdomen pain, it doesn't fit to a NIVEL. If a patient tells you I have dizziness, it doesn't fit to a NIVEL. You know, I am not a fan of those compression syndromes combination. If a patient has a swelling of the left leg, tension, and that could be a NIVEL, then you go for the duplex. And this is really the most important tool for diagnosing the NIVEL. And very important, my first sentence is, please perform the duplex in supine and upright position. Only a duplex in supine position doesn't allow us to diagnose a NIVEL. That is really very dangerous because many of our colleagues perform the duplex only in supine position. Then they add a CTV or MRV, which is also performed in supine position. And those young ladies, they have a compression. But this is not a really fixed compression. So perform the supine and upright position duplex. And very important is do not look only for a compression, also look for some changes of the vein wall, like the image on the top right of the slide. You see there is a fibrosis of the vein wall. And maybe check also, like on the image on the bottom right, the reflux in the internal iliac vein, which shows you a hemodynamical irrelevance of the stenosis. Should we go on with this slide?
Yes.
So now please focus on this video, which is done in my outpatient clinic. This is the corresponding MRV of the same young lady. So the lady is now in my outpatient clinic sitting on the bed, and I sitting but in upright position of the body. I start the duplex in upright position, and as you can see here, there is zero stenosis. This is the vein, this is the artery, this is the bone. And just have a look. I start it. There is no stenosis. Now I ask her, go to supine position. The same lady has a severe stenosis suddenly. So this is the wrong diagnosis. This is not a nivel. And this is also the reason why after treatment, the probability of the migration of the stent could be higher even, because there is not a fixed stenosis. The same lady, that is very interesting, we sent her to an MRV. Of course, the lady in supine position has a severe compression. So it is very clear today, do not make a diagnosis of a nivel or May-Thurner syndrome based on MRV or CTV. It should be based on past medical history, present illness, plus a dynamic duplex in supine and upright position.
That's fantastic. We totally agree with you. That's a very important thing to analyze in both positions in order to not do over treatment.
Yes. So I do not know if would you like to have a stent in your body without having a clear pathology. So that should be really the focus. Then we go to the next step. If you have really a patient which has a pelvic venous disorder with clear varicose veins in the pelvic area with a clear fixed stenosis, we can discuss, for example, if we should stent the lady. And if I have a fixed stenosis after all those steps, then I schedule an appointment for phlebogram in readiness for intervention. This is the last step. That means the lady or gentleman, the patient is coming to me. You can do it in angio suite or in OR. You do the phlebogram from the common femoral vein, the transfemoral approach. You give a dye. Then you see if there are signs of hemodynamical stenosis in the phlebogram. And then from the same approach axis, you can use also IVUS. So with those all information, your duplex, your cross-sectional imaging, taking into consideration patients' complaints, patients' past medical history, taking into consideration your phlebogram and IVUS, you decide if the patient needs a stenting or not.
Yeah.
And some of those patients, even I thought it could be a nivel, I decide in the OR not to stent.
And is there any case that the IVUS changed your intention, even with a positive upright position?
I think the role of IVUS is really important here, but less to ruling out, more for me to determine the landing zones and make a precisely stenting if I decide for stenting. So if you have those findings, a fixed stenosis in your duplex, you go to OR and you have a clear sign and symptoms in the OR of, let us go here, such a phlebogram, it is clear that in IVUS you will have a stenosis. If you use IVUS, then please do a Valsalva maneuver Yeah, if the patient is sleeping in general anesthesia, then do the positive PEEP. So then you will see if the stenosis is fixed or not. Because also consider in the OR, in your angio suite, patient is supine position. So IVUS will show you always a waste of the common iliac vein or of the confluence. So that is important. Do not stent the patient because of a waste in IVUS. That is the reason of also of over-treatment, over-diagnosis in US. Use the IVUS to reduce radiation exposure. Use the IVUS for precise proximal landing zone and distal landing zone. That is the role of IVUS. And here you see clear signs. You see the collaterals. You see the pancaking of the confluence. You see the pre-stenotic dilation. This is a picture of south of Malaga. Thanks to my friend Alejandro Morata. This is from our center. You see the reflux in internal iliac vein. You see also here the reflux in internal iliac vein. There are clear signs of a hemodynamically relevant stenosis.
Yes.
So till here it was patient selection. Diagnosis, patient selection. Very important.
Yes.
Yeah.
Yes, it's a very important step, and it's amazing how, in general, it's not discussed. The importance of proper selection, the role of each tool
Yeah.
on doing the selection, and it's really important to emphasize the importance of performing the duplex on supine and upright position.
I think it is also important in chronic venous obstruction. It is important in diagnosing pelvic venous disorder, even varicose veins. You know, you should go for supine and upright position.
Yeah, we totally agree. Yes.
Should we go on?
Yes.
Yes. So now let us assume we have all those steps positive. So patient has really pelvic venous disorder with clear pelvic symptoms. That is very important because also here we have some different kind of approaches. If the symptom of patient is extra pelvic, let us say with vulvar varices, it doesn't mean that we have to address a hemodynamically relevant stenosis. We shouldn't think physically here. We should treat patient symptoms. In those patients, many centers treat bottom up. That means treat first the vulvar varices with very good results. So maybe in the next step, we can go for stenting. But let us assume there is a hemodynamically relevant stenosis, and we would like to go for the next part, which is the phlebogram in readiness for intervention, which could be a stent. So very important is what should be taken in consideration and avoided. First, 100% migration. Even 1 to 1,000 migration is too much because NIVEL is not a life-threatening disease. It's not a huge aneurysm, aortic aneurysm, which can rupture and patient can die. We are talking about swelling of the left leg, heaviness, or maybe pelvic symptoms. So migration, even 1 is too much. Jailing of the contralateral side. Like in this case, on the second image, you see the stent has jailed the contralateral side, and the contralateral side, which was healthy, developed a DVT. So that is too much. And it is reported up to 2-3%. The third image, video, which is running, you see the post-intervention duplex. You see the stent, which is 1-2 centimeters short. So that means the poor lady or gentleman came for NIVEL stenting, and the stent was deployed, but it didn't treat the maximal point of the compression. It was too short. And also the last CT in coronary plane, you see the stent is 2 centimeters too short. So those problems should be avoided, especially migration and jailing. With that, you should know the exact landing zones in order to have the best stenting. in a nivel, you have a proximal landing zone and you have a distal landing zone. I'm not talking about PTS now. I'm talking only about nivel patients. The proximal landing zone is somewhere at the confluence, and the distal landing zone is very important. It should be in the middle of the external iliac vein. So with that, you might think, okay, it's a long stenting for a short pathology. Yes. Here, I would like to address, please use longer stent in a nivel, because with that, you can avoid migration, 100%. If also you take the good size regarding the diameter, then you take a longer stent, let us say 150, 15 centimeters. The distal landing zone will be in the external iliac vein. You have a perfect alignment, and that will prevent any migration. So how do we determine the proximal landing zone? Patient is in supine position. You have the access transfemoral. You use IVUS. It's mandatory. We addressed it already a few minutes ago. With IVUS, you make one recording, then you go to the live, and then you pull and push the IVUS through an area of the maximal point of the compression, and with that, you can determine exactly the maximal point of the compression. You can exactly tell this is the artery which is making the real compression. Then you do, from your ipsilateral approach, you go for a short crossover maneuver. You pull back the catheter and give a dye. And with that, you visualize exactly your confluence. Do not give the dye, the contrast from the introducer sheet, because it runs on the ipsilateral side and you cannot visualize the confluence properly. If you do the pull-back crossover technique, you visualize it properly. Then you draw on your monitor the confluence. You draw the maximal point of the compression, which you determined by IVUS, and this is exactly the picture you need in your OR or angio suite.
You puncture the
common femoral vein.
The common femoral, but to introduce the second catheter, you do a separate puncture.
No, you use a 10F. We have 11F, but you can use also 10F. You need it anyway for the stenting and ballooning and that predilation. You can puncture just beside your first wire, you see? Exactly. You have one wire placed there. This is a super stiff wire. Then you take a Terumo wire with an angled catheter. You make a very short, it's additional 5 minutes crossover. You pull it back, and you have the IVUS here. So this is your picture, what you need. And with that, you can absolutely properly place your stent. This is how it looks in a daily work. You see the dots are the border of the overriding artery. You see the confluence, and then you decide for the stent. This is the proximal landing zone, which was few millimeters longer as needed. That is very important. With that, we could avoid 100% jailing, because many centers, they just rely on bony landmarks and put a stent to the contralateral IVC wall. And this is 100% jailing, and it creates 2 to 3% of contralateral DVT, which is too much for this kind of pathologies.
Shall we speak here a little bit about the stent that has to have special characteristics?
Exactly.
To have radial force stronger at the first centimeters.
Absolutely.
And of course the angulation of the oblique angulation.
Absolutely. I will come to it with a case example, and then we can focus on it.
Okay.
So the proximal landing zone, any stent you take, you should determine it perfectly. And the distal landing zone should be in the external iliac vein, avoiding migration. So please take the shortest stent, in my eyes, for my fellows, it's 100 millimeter. So 10 centimeters, not shorter. No 6, no 8 centimeter stent for a nivel. Better is 150 for me, or 120, to have a perfect alignment in the distal part, preventing migration. And look, the post-op follow-up, how precisely the stent was deployed. You can see it in the duplex. Now you addressed the shape of the stent, the geometry of the stent at that point. I think we agree at the May-Thurner point, nivel point, we do not need a high flexibility. At that point, we need high radial force to address the maximal point of the compression. So there are stents, like, for example, here is the sinus oblique, which has a 4 centimeter of the stent geometry with very high radial force. Of course, the higher the radial force, the less the flexibility, because you do not need the flexibility at that point. And then the stent has a tail. I wouldn't take this size of the stent. I would take longer, as I mentioned. The distal part is based on the sinus flex, which is a flexible stent. So that is the part which goes to the common iliac, distal part of the common iliac, to the maximal point of the curve, where the internal iliac and the external iliac comes, and hopefully the distal part will land in the external iliac vein. So a very good high radial force at the maximal point of the compression.
Mm-hmm. And how do you perform the diameter sizing?
So of course you have IVUS. With IVUS you can check your distal landing zone. You have maybe a cross-sectional imaging before, or your duplex, you can size the contralateral side. But to be honest, in a daily work, we do not size because veins are very dynamic. Today it could be 12, and 1 hour later or tomorrow it could be 13, depends on the hydration situation of the patient. I think 80% of our patients, or 85, needs 16 in diameter for nivel, and the other rest needs 14. If I have a very big patient, very seldom 18, and if maybe a patient is really small, maybe 12, but to be honest, I haven't used a 12 for the proximal landing zone, for the nivel. So with 16, you can address probably 80% in Brazil of the population or of the patients. So a 16, then you go for the length. Of course, you have your phlebogram, you have IVUS, you determine the distal landing zone, and then a 16 to 150 probably would work for the majority of our patients, if we decide to stent.
Do you use any sizing catheter like a...
No, never. You have the IVUS. IVUS has you can properly measure the diameter with IVUS. That helps a lot. You see it already, how big the vein is.
Even the length.
Even the length you can see with IVUS. Yes, the length we properly measure with the IVUS. Yes, maybe, yes, that is the perfect stent. This is the stent we would take, the oblique 16 to 100. I do not know, it's 150, I think, this is not 100. So this is the flexible part based on sinus flex, and this is the unflexible part, which has the very high radial force. And you mentioned also the geometry of the stent. Mm-hmm. In order to decrease the amount of jailing of the contralateral leg, they designed an oblique shape in the proximal part which addressed this problem. So you can properly treat the maximal point of compression without unnecessary jailing of the contralateral leg.
Para os nossos as pessoas que estão nos assistindo, talvez jailing seja uma palavra não conhecida de todos. Isso em português quer dizer aprisionamento. Aprisionamento da artéria, da veia ilíaca direita pelo stent que está implantado na ilíaca esquerda. Jailing is not very well known from every...
It's the overstenting or the...
Yes.
Yeah.
Imprisoned would be...
Yes. Yes. Of course, we have to consider the new dedicated venous stents, also like oblique. The porosity of those stents are very big.
Yes.
In comparison to wall stent. Wall stent has very small holes. Of course, this will disturb the contralateral flow much more than a dedicated venous stent. That means if you have to go 50% into the contralateral flow, a new dedicated venous stent makes sense because they have less porosity.
And also to implant the flow from the internal iliac.
Also that, yes. I didn't see any problems with the new dedicated venous stents regarding the internal iliac flow. But yes, just have a look on the holes. The material burden of this stent is very less. So there are, big holes between the struts. So that is a case maybe to show you the importance of this geometry. This patient was treated in another hospital because of a chronic venous obstruction. They did the stenting, but patient had still complaints. It was not very clear why. They did the CT scan and they talked to us and sent the patient to us. On the CT scan, you can see the maximal point of compression is not properly addressed. The stent was 1-2 centimeters short. And you see also the angle of the confluence is a close angle confluence. It is different a little bit between patient and patient. We have some open angle or more smaller angle, closed angle. Here, the venous confluence is close. Then we went into angio suite. We did the crossover phlebo. We did the IVUS approach with determination of the maximal point of the compression. As I told you, in same way, we draw it on our monitor and we decided in this case clearly for a sinus obliquus. You see, we could address the pathology on the right part of the slide, the last image, and we could avoid 100% jailing of the contralateral side thanks to this geometry, in this case, in this kind of confluence. If I would have used, in this case, a non-oblique stent, I would probably 100% jail the contralateral side.
Yeah, and I think it's a very nice opportunity to show our colleagues that are at home the importance of addressing the point of maximum compression. And most of times, part of the cava, of the bifurcation of the cava, is included in that compression. And you need to treat, you need the stent to go over it. Sometimes in Rio, we receive Centervasc patients treated on other hospitals, and with a situation of a stent that does not address the compression, patient evolutes with thrombosis. Like you also receive these patients in Germany. And I think it's very important to people to have that in mind. You need to treat all the compression. You need the stent to go all over the compression. And dedicated stents are a very nice way to go to address it without jailing.
Exactly, that is the point. Because if you just go to the common iliac vein, like in this case, in many cases, you are too short. So you do stenting without any good results. So without addressing the main pathology. Sure. If you go over the pathology, you have to make it very precisely. We are talking about really few millimeters. It is not enough today just to rely on bony landmark and put the stent somewhere, because then you might jail without need. Sometimes you need. Sometimes the pathology, as you told, is very far inside the cava. Then you have to jail. Then you use a new dedicated venous stents with high porosity, which is okay. But if it is not needed, like in this case, you can stop exactly after treatment of the pathology. So another case maybe to show you, does oblique shape matter? This patient had already treatments, as you can see, many coils bilaterally because of a pelvic venous disorder. They treated the ovarian veins, and the patient came to us. We are not talking about if the indication was good or not. We did the stenting, and that was the contralateral leg, and that was the stent, a very nice new dedicated venous stent, and that is the contralateral flow in this case. And as we can see physically here, we jailed 90% the contralateral side. And my question is, what if we would have taken here an oblique? That would be the case. So the jailing would be here maybe 20%, 30%. If we can translate it one-to-one to the clinic, to outcome, we do not know. We need more results, we need studies, but physically it makes sense in some kind of the confluence to go absolutely for the oblique shape.
This is left oblique?
This is a sinus, that would be like a sinus oblique. Look.
No, but the oblique view, it's left. You angulated the arch to the left?
Yes.
To the left?
Yes, to the left. There are some techniques. There are markers. There is a side port of the stent, of the body of the stent. With those, you can absolutely go for the right positioning of the sinus oblique. And the other advantage of the sinus oblique is it is a pull-back mechanism deployment, but it has 4-5 centimeters of a pull back which you can reach it again. So the point of no return is after 5 centimeters, and it is marked with a red line. So you can open your oblique in the confluence and see the correct shape. And if you don't like it, you can resheet it again and reposition it, and then go for definitive deployment. So I think in summary, only symptomatic and hemodynamically relevant Nivel or May-Thurner patients should be treated. That is really the most important part. Then you need a very, very profound approach, diagnostic approach, taking consideration patients' complaints, past medical history, then a good duplex ultrasound. We add always a cross-sectional imaging just to have all informations if we decide to go in OR. Then you go to OR for a phlebogram in readiness of intervention plus IVUS. I think then you have all information today you can have, then you can decide if you should stent or not. And if you decide for the stent, go for the correct stent geometry, correct sizing, and it is not only diameter, we are also talking about the length of the stent, which is very important to avoid migration.
Yeah, we totally agree. We always, since the beginning of our experience with the venous work, we always implanted the stents on the sternal. I think that's a very nice way to have safety on those procedures, because we could not risk those patients on an embolization of those stents. As you said, those are patients that are not of a life-threatening pathology, and that's a very important thing to tell to people
to
at
take
home.
in consideration.
Yeah, that's true.
Thank you very much, Jalaie. It is a very nice presentation.
Thank you very much.
And we agree, I personally agree with all you said. And
thank you.
And I must tell you that we never had a migration. We have around 200 cases treated, and never had I had a migration also. It's a terrible thing.
I had one migration in
superior vena cava.
Exactly. I had one migration in superior vena cava, which I could treat with lengthening of the stent to fix the stent through the heart, so through the right atrium into the IVC. Patient was end-stage disease and passed away a few weeks after this, not because of the migration, luckily, but it should be taken in consideration. If you have a migration in a Nivel case, which even the pathology is not very clear today, This is a catastrophic case.
Open sternotomy.
Exactly. Open sternotomy patient can die even if you cannot retrieve it properly.
We are anxious to see your presentation about classification. I think this is very important too.
So
please.
That means we should jump now to the PTS, post-thrombotic cases.
So. Yes.
I just want to ask you something.
Yes, please.
How often do you encounter May-Thurner Syndrome as part of broader pelvic venous disorder? And how does that influence your approach?
Yes, that's a really good question. I have a lot of patients they come with pelvic venous disorder, I told you. A very solely nivel patient coming to me, or maybe to other big centers, is very seldom. And if they come, a big part are overdiagnosed because somebody saw in a supine position a compression and then said, oh, there is a nivel, and then send it to you. It's very difficult to diagnose them. You should be very strict. More they come to you with in a combination of this pelvic venous disorder. They have ovarian vein insufficiency, they have some pelvic symptoms, extra pelvic symptoms, like atypical varicose veins, vulva varices, or really pelvic symptoms like lower abdominal pain and discomfort and those things. And then you have to approach them and see if maybe there is also an obstruction like nutcracker or a nivel. I would see mostly the patients don't have a nivel, patients with pelvic venous disorder or a nutcracker. And even though you shouldn't treat all compressions directly because of a hemodynamics, because you think physically, oh, there is a nutcracker compression. Of course, the nutcracker compression creates the ovarian vein insufficiency, so I have to treat the nutcracker first. It is not correct. You have to treat the nutcracker first only if the patient's main complaints are left flank pain, really heavy left flank pain over few months or years better, plus microhematuria and proteinuria. And ruling out everything else like endometriosis, urological problem. Then you can take in consideration to treat the nutcracker, because also the trapeze is a big procedure. In a nivel, the trapeze is easier, is a stenting, but also there you should really consider in a pelvic venous disorder patient to treat the symptoms. If there is really a very fixed stenosis in duplex, and you see a reflux in internal iliac vein, in my eyes, and the problem is the pelvic problem, not extra pelvic problem, you can schedule a date, appointment for phlebography in intervention, readiness for intervention, and then you can treat it. So a smaller part of the pelvic venous patients need stenting. But then, of course, you should really respect those rules for stenting. So this is the new classification of chronic venous obstruction. Now we are changing from nivel to chronic venous obstruction. So patients who had already DVT years ago and developed PTS based on chronic venous obstruction. So this is a nice slide. I like it. I'm not changing now the topic to aortic, but I ask you, if you see two pathologies or two kind of patients, both pathologies are involving the same organ, it is aorta, and both are the same pathology. This is aneurysm of aorta. This is also aneurysm of aorta, right?
Yes.
Yes. If I would publish my data from Aachen, and you read my paper and you see I publish the results after treatment of these both pathologies, same organ, same pathology, you probably think he's crazy. He's mixing AAA with thoracoabdominal aortic aneurysm. You wouldn't accept it. You say, yes, what should I tell now? Of course, the AAA has a very low mortality today, is a very nice approach, endo, open, we are not talking about this, with low morbidity, but if you treat a thoracoabdominal aortic aneurysm, the mortality is much higher, the morbidity is much higher. So the same is here. These are different kind of PTS patients, not DVT. I'm talking about PTS, chronic cases. And I can tell you, if you take the left PTS and the right PTS, it is a little bit like thoracoabdominal aortic aneurysm and comparing it with a AAA. So regarding the difficulty of the procedure, regarding the patency rate, regarding the outcome, because the inflow on the right side is heavily involved and the inflow on the left side is no involved. There is no involvement of the inflow. And if I treat this PTS case, the patient will be very lucky with perfect outcome. If I treat the right patient in the same center with the same stents, the patient is not that lucky because the patency rate is very, very, very low. That is the reason why we decided together with 12 other centers to go for this classification. And this is the classification. Type 1 is a nibble. That could be a compression somewhere. From type 2, we go to PTS. The type 2 is very seldom. Only iliac tract is involved. And please consider, regardless of IVC. IVC could be involved in all those cases. It doesn't matter. It doesn't affect the outcome. IVC affects maybe the difficulty of procedure and the time of the procedure. You need some other techniques, but it doesn't affect your outcome. Very seldom. Then the type 3 is very common. We know it. Common femoral vein is involved. The stent should come into the common femoral vein, but luckily you have a good femoral vein and good deep femoral vein. Then we go to the so-called extensive disease, inflow disease. The 4A is very common. Femoral vein is also involved. The only inflow vein is the deep femoral vein. 4B is very seldom, is vice versa. And group 5, we have also 20% of those patients who are very unlucky because they have really low inflow veins. And based on this classification, these are the therapeutic approaches. The type 3 needs only endovascular technique. You recanalize everything. You do not need any endophlebectomy or those kinds of hybrid approaches. You put the distal part of the stent just above the ostium of the deep femoral vein. Then you go to the 4A. Here you might need endovascular and endophlebectomy or some special endovascular techniques. Today we avoid endophlebectomy. The same here in the 4B. And the type 5 normally should be considered as contraindication for recanalization because of a very bad outcome or patency rate. But in a non-healing ulcer, in exceptional cases, you should go for recanalization, of course, but you should do something for the inflow, which is the femoral vein, to restore some inflow. You cannot recanalize and you have no erythrocytes running into your reconstruction. It doesn't help the leg and it will occlude. These are the patency rates. These are not the patency rates of our paper. Of our paper, we had to reduce the report to 2 years due to loss to follow-up of many patients. So we reported in our paper for 2 years, but this is before the paper was published. Just showing you, maybe here you cannot see very well, the difference between the patency rate of a type 2, this is the primary patency rate, which is 90% after 1 year compared to type 5, 40%. Or after 2 years, 85% compared to 25%. And the both pathologies today are called PTS.
Are these patients kept under anticoagulation?
Also different. If you have a type 2 and you have a perfect inflow, we go for 1 year. In a nibble, we go for 6 months. In a PTS type 2 with perfect inflow, we go for 1 year. But in a PTS with bad inflow, let us say 4A, classification 4A, we go minimum for 2-3 years, and then depends on your follow-up results with duplex, maybe for lifelong. Mm-hmm. That means also an advantage of this classification, maybe later, also with the help of new results of the studies, we can adapt also our anticoagulation regime to the classification. So
speaking from antithrombotics, do you use any kind of antiaggregants together with the anticoagulants?
If we have a reocclusion because of a bad inflow and we do the thrombectomy and lysis, then we add always aspirin to our anticoagulation, oral anticoagulation.
And in NIVL?
In a NIVL, there are many centers using only aspirin or antithrombotic agents. We use anticoagulants for 6 months. And there are also centers, they use it only for 3 months. I know also centers, they don't use anything. They just heparinize the patient peri-interventional, so during the intervention, and that was it. So no consensus.
And what can you talk to us about the endophlebectomy? How do you perform it?
Yes, the endophlebectomy, I did a lot of endophlebectomies, 2012, 13, 14 was the peak. I did 2 cases a week, recanalization and endophlebectomy. And with that, after years, we could publish, we could analyze our results. To be honest, endophlebectomy, yes, you make a cut down, you open the vein. Of course, before it is now, in theory, it's very easy, but it needs 2 hours, 3 hours. You have to control all the tributaries. Normally it is a hostile groin, due to DVTs, 1, 2, 3 DVTs. Many of those patients had already open thrombectomy approach years before. Many of those patients developed wound healing disorder. 20%, 25% had lymphoria, wound healing disorder. And we could see that in the same group of patients, the 4A, who might need the endophlebectomy, we could manage with the same results without endophlebectomy, but with clearly less complications and shorter in hospital stay. So with that, 2014, I performed twice a week endophlebectomy. Today, I do perform 2 endophlebectomies per year. So it's a huge difference. So we do not need endophlebectomy. It's only today for bailout situation. If you do the endovascular technique, you use the IVUS. You have to use it to determine the distal landing zone. You put a stent, and then you do again an IVUS analysis to see if you have a flap, a membrane of post-thrombotic changes between your only inflow, which is the deep femoral vein inflow, and your reconstruction. If you have this flap, you have to go from jugular approach and to rupture this flap with the ballooning. If it is not possible, you have to do the cut down and the endophlebectomy. This is the only indication for endophlebectomy today.
And you have any special concern when crossing the groin with a stent? Do you choose a special stent for that?
I know I am crossing the groin, and in type 3, 4A, 4B, and 5, you have to cross it. So in the majority of our patients, you have to cross the ligament. But I have no concerns today, to be honest. I know it is a special part of our venous tract, of our reconstruction. Maybe the compression is a little bit more there. Maybe the stent, you have to do a very good predilation there. Maybe the stent has a little bit decreased area, measured area at that point, but it is okay. I am not concerned about it. If you use the new dedicated venous stents, I have here, for example, the Sinus Venous, which is a very flexible stent, as you can see here. It's a segmented stent, and each part has a good radial force. If you start with the sinus oblique in the proximal part and lengthen it below the ligament with the sinus venous, it is fully okay. And also there are other dedicated venous stents on the market, all perform very well below the ligament. You should treat the pathology in the common femoral vein. That means in those patients you have to go below the ligament.
Good inflow is mandatory. No?
Inflow is mandatory, of course. You have to restore the best possible inflow and treat the outflow obstruction.
Yeah, I totally agree with you. I have a very interesting case some years ago. There's a patient that I treated like 15 years ago, and I crossed the groin. And she is actually very sportive, and she
Lady,
loves,
yeah.
she loves action sportive. And she asked me if she could do snowboarding and wakeboarding and skiing. By that time, we don't have a lot of information,
Yes,
like
from me,
but
exactly.
she made anyway.
Yeah.
And I always I made the follow up with X-rays or
Yeah.
CTs.
Everything's okay.
Everything's okay. But the only thing that I noticed when she got she lose a lot of weight, she started feeling some pain
Some
in the groin.
yeah.
And I asked her to regain the weight,
Yeah.
and the pain disappeared.
disappear. Exactly. That is experience which many centers saw the last years, exactly with us. 2010, I didn't know if endophlebectomy is better or only endovascular technique. Then we developed some techniques. We learned from other centers. So we are learning and learning. And now we see, okay, the inflow is the most important aspect affecting the outcome. Endophlebectomy is not needed. You can do everything in endovascular technique only for bailout. And also some pains after stenting. I showed you the images of a young lady, 22 years old, with a stenting for nivel, correct indication, correct stenting, everything was okay. But this young lady developed severe pain. She had really 100 approaches of different specialties, gynecology, urology, psychiatry, neurology. Everything was ruled out, and the patient had such a pain that she couldn't even walk in upright position. So as a ultima ratio, so as a really last help, she was referred to us to take the stent out. So now I after really profound conversation with her mother is a medical doctor, so they did understand everything, and then we did a laparotomy and removed one big part of the stent and reconstructed the confluence with the PTFE. 1 day later, she was without any pain. So, but this is not, it is a really seldom case. So it is maybe...
Ring PTFE.
Ring, yes, external supported PTFE, 12 millimeters. And we shaped it, the proximal part, as a new confluence. Yeah. It worked very well. But I didn't know if she will be without pain or not after the resection. So, but luckily, it was a real pain. The same could be in 1 to 200 cases below the ligament.
Yeah, that's true.
Okay. And pelvic pain after stenting. How do you treat it? I have many patients that...
Yeah, they start with pain. Many of those, maybe all of them, they have the first hours and first 1-2 days pain, but then the pain is decreasing, going down, and after 1 week, 2 weeks, they don't have any pain anymore. Some of them report in some special situations that they feel the stent, which is okay, they can live with it. But of course, therefore, the indication making is very important.
Yeah, we had some cases, we don't have very much nutcracker patients treated, but I remember one that she had permanent pain for some months, and the only treatment that really worked out were corticosteroids.
Yeah.
And subsided. Yeah. Okay, Bernardo, I think.
One, I actually have a last topic that I would like to address with you regarding thrombectomy. What is your approach for the acute cases when the patient comes with phlegmasia and on your hospital?
Phlegmasia is very rare,
Yeah.
very seldom, the real phlegmasia.
Yeah.
Not every painful leg, swollen leg, and blue leg is a phlegmasia. So phlegmasia is really, really seldom, but then there's a clear indication. Today, my approach is acute, iliofemoral DVT in a mobile patient, so in an immobile anyway patient who is only in the bed, you shouldn't do an the thrombectomy. So in a very acute, younger, active patient with symptoms, iliofemoral, and the best kind of the DVT is the descending DVT, I would consider clearly an intervention. And then I would talk to the patient. Many of those patients do understand. If you talk also about evidence and some research and where we are, and then you can treat these patients. This is my idea. So in those patients, I go for intervention in order to prevent PTS or at least decrease the PTS.
Do you have any preference nowadays?
For a technique?
Technique.
So I try to go for percutaneous mechanical thrombectomy without lysis, or if needed, then additional lysis, local lysis. So there are some techniques we use like clot river, like Jalaie, which is not going to be supported anymore, like penumbra. So these are, and of course, other devices also on the market, Aspirex. I am for treatment in really selected patients, yes. And then if they need stenting after removal of the thrombus, if you see the underlying disease, in my eyes, 85% of those patients need stenting.
I see. Our experience is exactly the same.
Yes, yeah.
I believe I was the first one to perform venous thrombectomy 47 years ago in this country.
Really?
I learned by Professor Vollmer, which was my mentor in Germany, and I started at the first case, I think I did in 1978. Many of you weren't born yet.
I was 2 years old.
Yes, and we do most of our cases have a growing experience with mechanical thrombectomy, although we tried almost everything. And the clot river has been excellent results.
Yes.
Yeah. Although we have others too, like penumbra and, as you said.
Yes, there are some cases you cannot use the clot river. You should use then the penumbra or Aspirex or Angiojet or X and Y.
The no need to lyse the patients is really incredible. Huh?
Yes.
Because the complications are seldom, but they can be overwhelming.
Devastating, yes. But still there is a place for local lysis. Today, if, for example, you have an instant thrombosis. If you have an instant thrombosis, even you do the percutaneous mechanical thrombectomy, the results are not that good as in a native vein. You need, in majority of cases, in my eyes, in all cases, additional local lysis.
So, okay, I would like to thank our guests, our special guests to this episode of Clube da Artéria. It was very nice to be here with you, Houman.
Thank you very much.
Yeah, we really enjoyed hearing you and discussing all that excellent material you show us. It was really a pleasure. Thank you very much.
Thank you very much.
Thank you.
Thank you very much. Very much.
Então, amigos, esse foi mais um episódio do Clube da Artéria. Queria agradecer a todos vocês por ter ficado conosco aqui durante essa 1 hora, discutindo esses temas de suma importância. Muito obrigado. Até o próximo episódio. Um abraço.